afternoon, everyone. It's our pleasure to welcome you to, as far as we know, the very first session at an AIDS conference that focuses specifically on key population-led health services. So we're very excited to welcome you to this dynamic session where we'll hear from panelists from around the world about their experience with key population-led health services. So I'd like to introduce myself. My name is Kimberly Green. I work with PATH in the Mekong.
Good afternoon, everyone, and my name is Nitya Panupak. I'm working at the Thai Red Cross AIDS Research Center.
So we'll start off first with a few slides just to provide some context around key population-led health services. So I'm just going to transition to up there. If I'm successful at this, let's see. No. No. Well, oh, it looks like there's maybe, I think somehow we were unsuccessful in loading the slides. Okay, well, I think I'm just going to, I'm going to try to explain as visually as possible so you can imagine the slides. So essentially the message is that we know that the HIV epidemic globally is heavily dominated among people, key populations, around 44% globally, and that's particularly outside of sub-Saharan Africa. And we also know that new HIV infections are relatively stable in these regions around the world, including in Asia, in Latin America, South America, but we also see significant increases in Eastern Europe and Central Asia. And so this essentially tells us that if we are going to address gaps in HIV prevention and also gaps in treatment, that we have to do a much better job in terms of getting towards epidemic control. And for us here, and the panelists, they'll provide more information on this as they speak. We believe it's key population-led health services which will get us from where we are now to epidemic control in the future. And when we think about what key population-led health services are, there's quite a wide range, but effectively it's where you've got lay providers who are trained or professional healthcare workers who are offering anything from risk screening to counseling to HIV testing services, adherence support. And we've also seen recently that HIV testing services have opened the door for key population-led testing in other areas, including syphilis and HCV. And increasingly in places like Vietnam, in Thailand, and South Africa, we see that key populations are establishing their own clinics and offering services themselves to their peers and to others. And so with this panel here, we'll be answering the question of why key population services matter and what more we need to do to extend them in countries around the world. So with that, I'll turn to my co-chair who will introduce the first speaker.
Thank you very much, Kim. We will start to learn about KPLHS from different perspectives from our panelists here on the panel. We will start with Svetlana Moroz. Svetlana is an HIV-positive women's rights activist from Georgia. She's one of the founders of the Union of Women of Ukraine affected by HIV-positive women. And since 2013, she has coordinated activities for the Eurasian Women's Network on HIV AIDS. So Svetlana will talk about the perspective of being key populations affected by HIV. Svetlana, please. Let's try. I think yours are okay. Are the slides working? I think it's only probably mine. Yours is perfect.
Thank you. Just little clarification. I'm not from Georgia. I'm from Ukraine. I work in organization registered in Georgia. So I would like to start and remind about political declaration, last political declaration on AIDS, which acknowledged the vital role of community-led services in ending AIDS epidemic by 2030. It calls for the proportion of services delivered through community-led channels to reach 30%, and for investment in social enablers to account for 6% of global AIDS investment. This is supported by global experience, which shows that an effective HIV response is only possible if government and key populations cooperate and share leadership. And yet, in the Eastern Europe and Central Asia, communities most affected by HIV faced a considerable threat to their continued engagement as actor in the HIV response. As external donors' investment decrease, access to and the quality of HIV medications and commodities remain unacceptably low. Human rights continue to be violated, and the quality of many services continue to be inadequate or of questionable sustainability. People who inject drugs have long experienced a significant epidemiological burden of HIV in Eastern Europe and Central Asia, accounting for 42% of new infection in the region. HIV prevalence among people who inject drugs range from 8.5% in Kazakhstan to 25.2% in Belarus, and has reached over 60% in several Russian industrial cities. Across of the key populations of people living with HIV, there is an additional element to consider in tracking epidemiological trends: gender. In 2016, 14% of all HIV cases reported in Kazakhstan were among women who use drugs. And yet there are no population size estimate for them in the country. So more sophisticated epidemiological calculation remains impossible. In Russia alone, the unofficial number of people who use drugs is 1.7 million people. It is estimated that over 57% of them are living with HIV. By extrapolated European data to Russia, it can be assumed that approximately 425,000 people who use drugs in Russia are women. Assuming that an estimate 57 of them are HIV positive, could potentially indicate that over 242,000 women who inject drugs in Russia are living with HIV. Medical protocols are widely unavailable to guide the prenatal care for women who use drugs. Women do not enroll in OST programs because of fear of being deprived of parental rights and blackmailed by state or social workers. OST not available during pregnancy and women's health clinic and maternity hospitals. And many medications prescribed for treatment of drug addiction are not advised during pregnancy. Women who use drugs are often pressured into terminating their pregnancies. In Ukraine, 80% of women who use drugs tested positive for HIV already in labor, and 11.8% after labor. 11% of these births resulted in vertical transmission of HIV. Slide 6 shows gaps in HIV prevention among people who inject drugs. While several Eastern European and Central Asian countries achieve coverage of needle and syringes program, which approach or exceed WHO recommendation of 60%. Opioid substitution therapy coverage remain very below the recommendation, 16 in the best cases. And in countries with the largest epidemics, Russia, Uzbekistan, Kazakhstan, OST is either not provided or it's below 1% coverage. Meanwhile, the single largest epidemic in Russia also achieves NSP coverage of less than 1%. Almost all countries in the region severe challenges in the enabling environment persist to marginalize people who use drugs and who is already oppressed due to their gender, sexual orientation, sex work, and drug use, and increase their vulnerability to HIV. People who use drugs facing multiple discrimination and marginalization. In many countries of Eastern Europe and Central Asia, the official reject people who use drugs registration as civil society organization and name them foreign agents. The existing repressive laws and structural violence prevent them to become human rights defenders and from participating in peaceful activities against violation of human rights and fundamental freedoms, and demand from the governments to take all necessary measures to ensure the protection by competent authorities. Institutional violations generally reflect popular opinion, which in turn drives political will and result in stagnation of policy and legislative change. This makes decriminalization of drug use and sex work, for example, extremely challenging. Criminalization has severe consequences for access to services, especially for women. Criminalization in Georgia, where women constitute 10% of the estimated people who use drugs, led to only 1 to 2% of them have access to services provided by Global Fund or government of Georgia. Yeah, little just to pay attention about the service delivery design and content. It's very important how we address the services, in particular harm reduction. And I want to share the very useful tool how to check drug interaction, which allow people who use drugs to understand how dangerous for them alcohol use with ARV treatment, with OST. It's developed by University of Liverpool and called HIV drug interaction. Please share and advise your friends and clients. And finally, I want to say that given that further reduction in the international contribution for HIV funding in Eastern Europe and Central Asia region are foreseeable in order to be as cost-effective as possible. HIV intervention must only focus on individual behavioral change, but also address the broader factors that contribute to people who use drugs vulnerabilities, such as criminalization and other punitive laws, bylaws and practices, stigma and discrimination, poverty, housing instability, violence and harassment, and limited access to health, social, and financial services. This intervention must be grounded in the best possible data to ensure decision making. And finally, of course, I need to say that chase the virus. Not people. Chase the virus. Not people. Thank you.
Thank you very much, Svetlana. And I think what we can see here is the experience of key populations in different contexts and different regions clearly requires different formulation of service delivery. And your point is very clear that there are underlying structural barriers and issues which create significant vulnerability, particularly for women who use drugs, that need to be addressed for better service delivery. And your last point is excellent, that services can only be delivered if through people who use drugs. So thank you. I'd like to welcome the next speaker. So we're moving from Georgia over to Brazil. I'd like to welcome Alicia Kruger. She's a transgender woman. She's a pharmacist. She's a master of public health. She is the current president for the Brazilian Professional Association for Transgender Health. She was also the first transgender woman worldwide to be the president of WPATH and is a technical advisor to the Ministry of Health. Welcome.
Thank you. Good afternoon, everyone. I would like to introduce my speech by thanking the co-chairs and IAS for allowing me to be part of such an important session. But mainly, I would like to thank and congratulate all the transgender persons in here, because you are the most important. You are and we are the most important persons in here. Okay. So I have no conflict of interest to declare. I would like to start by talking about our paradoxical scenario in Brazil. In the same country, recently we had that the Supreme Court allowed transgender people to change their name and gender officially in their documents without needing of medical evaluation or judicial decision. Moreover, Brazil's Supreme Court has also decided that transgender persons can apply to be candidates for election according to their gender identity by the gender political party quota. But unfortunately, otherwise, not everything is good news. Brazil is the country that most murders trans people in the world, according to TGU's data in 2016. Concerning health, in Brazil there is a national policy for the comprehensive health of LGBT persons established by law. It offers transgender people procedures such as hormones and surgeries totally free of charge. And it also establishes and guarantees respect and gender recognition for all within healthcare services. Talking about our main field, that is the HIV, Brazil monitors its concentrated HIV epidemic among key populations. As you see, this data show that transgender women are the most affected by HIV, highlighting the great and the multi-sectorial challenge that Brazil faces in offering this population access to health and other public policies. These data were collected by the Pesquisa Divas RDS study, the first national CAP and serological study on trans women in Brazil. And it's important to highlight that these data show that as transgender women, we are not men who have sex with men. We cannot be considered men who have sex with men, not even in Brazil or in other part of the world. Focusing on HIV, as well, to change the STI panorama in Brazil, the Ministry of Health has implemented a lot of actions focused on transgender people. This Pop Trans agenda, as we call, included, for example, Brazil's first booklet on the specific health on trans men. Yeah, because trans men, they matter. 2 web docs on trans women and trans men health. As well as to making PrEP available to trans people, both men and women, free of charge. The peer testing and education, that is, trans people test and share information with each other. And finally, strengthening strategic information by collecting specific data on trans people from our systems. There's an example. The systems field are synergic. If a person doesn't have a social name anymore, in case of civil change, as I said, the system captures gender identity, genital at birth, and sexual orientation. This synergy provides more robust data. Within the Ministry of Health, this agenda is led by a healthcare professional who is also a transgender woman, me. So next, I would like to highlight our major innovations in Brazil. PrEP and the Live Better Knowing strategy. Brazilian Ministry of Health developed a strategy called Viva Melhor Sabendo in Portuguese. In English, is something like Live Better by Knowing your serological status. To increase HIV testing among key population in partnership with NGOs. It's a peer-of-point care testing intervention using an oral fluid rapid test that was introduced at social venues for key population at different times of the day. According to its data, although trans people present the lowest numbers of persons tested, 38% of them had never been tested before. And it's also important to highlight that this population reached the highest HIV prevalence rate. 6% of the total. Concerning PrEP, this is a graph about the general profile of PrEP users in Brazil within its unified health system. Altogether, 2,735 persons are in PrEP in Brazil so far. This graph shows that most of them are cisgender gay men. Neither transgender women or men have had much access to this important prevention technology. Among the 69 persons who did, women and men, as you can see, most of them were white, young, and had more schooling. The general profile of the earlier adopters worldwide. That's because trans people in Brazil and worldwide face a lot of prejudice and discrimination, resulting in lack of schooling, employment, of civil and social rights, and consequently, the lack of access to health. To link more trans people to PrEP and the healthcare services, we must address the structural barriers that compound this framework, and then fight to create a positive environment for trans people. Talking about the steps to improve HIV prevention and care, taking this data into account and aware that trans people's first motivation when seeking healthcare services is the hormone therapy, yes. And if we really want to fight against the HIV epidemic among this population, we should integrate HIV services and hormonal therapy care, training healthcare professionals to manage hormone therapy, make safety assessment of hormone use and DRT use, and this is also valid for PrEP. Brazil is integrating PrEP services and transgender-specific healthcare services to work together in one unique flow. It's also important to carry out that trans health campaigns with real trans persons and finally, hire trans workers. We have one of the real trans persons right there, Kayla. So, the Brazilian Ministry of Health Department of STIs, HIV and AIDS viral hepatitis officially established Brazil's National Transgender Visibility Day in January 29 through the campaign Travesti e Respeito, in English, Travesti and Respect. The date is now celebrated annually. As conclusions, we have that positive legal scenarios for transgender people improve their linkage to healthcare services. Social determinants are fundamental to health. Established LGBT national health policies may favor transgender people's access to health services, and the opposite is also true. Involving transgender people in actions to fight the HIV epidemic and other STIs is crucial, such as in peer-to-peer education and actions and technical decision-making committees. And hiring trans people makes health services friendlier, I guess. Thank you so much.
Alicia, for your very energetic talk. And I think that we have heard now from two speakers about why and how we should go forward for the key population-led health services here due to all those criminalization, violence in the society, judgmental attitudes in the conventional healthcare settings, etc., which really impede the access to HIV-related services. And we would not see the impact of all the HIV treatment and prevention strategies that we are trying to do in our countries if we don't really seriously continuously engaging key populations. So I think that leads us to our next speaker, Dr. Margaret Hillard from Australia. Professor Hillard is the Deputy Director at the Burnett Institute and the Head of Hepatitis Services in the Department of Infectious Diseases at the Alfred Hospital. Her interest is around the prevention of transmission and improving the management of bloodborne viruses and STIs, focusing on people who inject drugs gained by sexual men and other vulnerable populations. She also is the co-chair of the WHO Strategic and Technical Advisory Committee on HIV and viral hepatitis. Please.
Thank you. So thank you very much for the opportunity to speak in this session. It's a real honour and pleasure, so thank you for the invitation. That said, it's a little daunting given the panel I'm speaking with and the topic, and that I was actually asked to speak about changing the mindset of health professionals and addressing structural barriers to support key populations. Because I think this is a tough thing to achieve. Changing anyone's mindset is difficult, but to change the mindset of people who have a God complex and know they are right all of the time is a huge task. But anyway, whoever said that the task had to be easy not to have a shot at it? So for me, when I'm considering solutions to complex problems, I go back to first principles. What are we trying to achieve? What are the health outcomes that we're trying to improve for the people who are affected by that? For this topic today, we're talking about ending HIV or eliminating hepatitis C or hepatitis B or whatever that may be. And if we're going to achieve this task, the data clearly shows us we need to engage with the infected populations. The affected populations need to be centrally involved. They need to be at the table. They actually need to be at the clinics. They need to be having testing. They need to uptake treatment. But this is not going to happen, and we are not going to achieve ending HIV or ending hepatitis or eliminating hepatitis C or B or the like if we think this is going to happen in tertiary hospital settings. It simply will not happen. It needs to happen in community settings where people from the affected populations are heavily engaged. So how do we get to this, and how do we get to health professionals who this is not their natural place necessarily, this has not been their training? So my way of thinking about this is, though health professionals, and although some of them may resent me saying this and other people simply may not believe me, are human beings just like most other people. So in my opinion, we need to take a standard approach to what we're talking about here, because what we're talking about is behaviour change. And so we need to think, how do we get behaviour change? And in the same way as your doctor may want you to stop smoking, exercise more, drink less, not take drugs but not the fun ones, have safe sex, have regular checkups, the list goes on and on and on as to what the community is being asked to achieve, then we need to do the same to the health professionals. What do we need from them? What's the behaviour change that we're looking for in them, and how do we do that? Now, there's lots of theories on behaviour change, and those that know me well would know that I'm not a theory sort of girl. I'm rather reactive and instinctive in my work, but nonetheless I recognise there is a benefit to some theoretical grounding in how we're going to achieve behaviour change in doctors, health professionals, nurses or whatever, because it helps to provide us with at least a bit of a loose roadmap of the way forward. And for me it also helps get research grants if I write some theoretical grounding. But key is what we're trying to do. So first we need to look at the principles of behaviour change for the individuals, and second, the broader influences impacting on that individual's capacity to enact change. We know this when we talk about ourselves, patients and people in the community, that we talk about what's the individual change that needed, but there's no point in even thinking about, somebody using a clean needle and syringe for injecting if they actually can't access to the needle. If we don't have harm reduction, if we don't have those things, the same comes with behaviour change in health systems. So there are numerous models, as I said, of theories, and I looked them up and they go on from protection, motivation theory, trans-theoretical, self-regulation, whatever. But in my view, the specific theory or model doesn't really matter, more importantly in recognising that's what we're looking for in our health systems and services. My experience in working with my colleagues, and it might be the nature of the beast of health professionals, is that they do like evidence. Evidence suggests that they act in a certain way to achieve a better outcome for their patient. Now, one can be cynical about the motivation of health professionals, but in my view, most are looking for better outcomes for their patients. They just haven't been trained into thinking about how one might do this. And the example I would give was a number of years ago now when I was beginning to treat people who injected drugs with hepatitis C. And I was at a conference on a panel similar to this where I was talking about treating people who injected drugs, currently injecting drugs. And I was accused by a couple of my colleagues of medical negligence for doing such a thing. And I can remember thinking, I'm pretty sure I'm not being medically negligent. The patient wanted treatment and I'm treating them. And they had lots of reasons because of their training as to why they thought I was being negligent. So it made me go away and collect evidence that showed that people who injected drugs, outcomes for HIV and for hepatitis C were just as good as people who did not inject drugs, that their compliance was just as good. So that next time I got accused of medical negligence, I said, I baked this one before at home. I think I'm the person that's following the evidence-based. I'm not being negligent. Negligence might be not engaging in treatment. So I think as researchers, we constantly need to be working to collect evidence to help our health professional colleagues to move on and actually have an evidence-based practice. It's not always their fault. The training is very poor. I was told the things I won't go into details for want of time, but in my training as to how I was to think about gay and bisexual men, drug use, various things. Now that lot has changed, but these things still happen with people. Another strategy when working with health professionals is to recognise they inherit competitiveness against their peers and to provide them with information about how they're tracking in their testing or their behaviour relative to their peers. And this is something at my own hospital that we do all of the time, where we provide feedback to surgeons about infections and the rate of infection. For my own clinic that I'm involved with, we were provided feedback, regular feedback, as to whether we were doing enough syphilis testing in gay and bisexual men who are HIV positive, and that to help us increase our numbers. Now, being the nature of the person I am, I don't want to miss anybody and I want to be the best person at the clinic. But all doctors are like that, so we need to recognise that. I think a key thing is also to not be blaming people. In the same way as it's really important as health professionals to stop them from blaming patients for why they put themselves at risk, why they don't turn up at clinic, why they don't do this, why they don't do that. We need to stop blaming health professionals and think about how do we get behaviour change to happen. And this needs to involve the key affected populations. The next thing we need to consider is the structural barriers that are impacting on this. And another sort of model of way of thinking about this is the social and ecological models of health. And when one thinks about those, you say, what are the factors that impact on an individual? There's the individual information and knowledge, that behaviour change I just talked about. But there's also the interpersonal, the community, organisational and the policy environments. And this again involves needing civil society and community to work with health professionals and health systems to change these things. If I alone am trying to do something and I have no support from civil society, nobody's backing me up, it's really hard for me if none of my other professional organisations are helping me. So we need to have health professionals being supported in that way. We also need what I would call champions from our health service professionals to be speaking up loud about how to move things on and the concept of moving testing into community, being driven by community, with health professionals supporting them. We need to understand the organisational barriers. So it's all very well and good to say, that's great, but if we cannot get that health professional's boss, the health service, the hospital, to say, yeah, we'll put some money, or the health department put some money into the clinics in community and provide that funding, we've got a struggle. So we need to work on that. And finally, as a couple of the speakers, our first two speakers have already mentioned, there's at that very top level, that policy enabling environment. It's all very well, in the same way as to say to somebody, change your behaviour. If it's an illegal behaviour or we don't provide clean needles and syringes, we make it really difficult for them. Similarly, if there's a legislative requirement that stops health professionals giving out clean needles and syringes, they are innately conservative people. That becomes a problem. So, moving forward, basically we need to work together. We need civil society and health services and professionals to work together to achieve this and to collect information about how to do that. And there are processes and ways to do that better. And it should be both when providing a new service, you collect information from health services about their barriers and for the community about the barriers to using the health services. I'll finish there and I'm sure there'll be further discussion, but I'd again like to thank the conference organisers for the opportunity to speak today. I'd also like to dedicate this talk to Jenny Kelsall. She was the CEO of Harm Reduction Victoria, who died earlier this year from hepatitis C-related illnesses. I learned an enormous amount from Jenny about the importance of considering the needs of the affected community when thinking about the provision of healthcare services. Thank you.
Thank you so much, Margaret, and thank you also as a doctor talking about sometimes the God complex that doctors do have, and also just about the need for doctors to be real champions of working together with the community and modeling that and showing that it's possible, and sometimes having to generate the evidence to prove that it's the right way to go. I now have the honor of turning to Thailand to introduce Mr. Pongthorn Changlun, who's the director of M+ Foundation, working on HIV prevention in Chiang Mai, Chiang Rai, and Pitsanulok. He leads community health services to promote free HIV testing to key populations, including men who have sex with men, transgender women, and sex workers. They are providing community-based prevention services and also engaged in a lot of community outreach work. He also is the regional president of Rainbow Sky Association in northern Thailand and has done a lot of advocacy related to the law in Thailand and LGBT rights.
Okay, thank you, Corinne. Thank you. I will use just one PowerPoint to explain the whole one. So it's not just the evidence base, but I would like to share based on our experience too. That you know, HIV prevalence among MSM in Thailand is still high. From the data of UNAIDS in 2016, the number of HIV/AIDS who infected with new case among MSM is so high, about 28.6%. There are gaps in treatment uptake and retention. This is a point that we have to concern. This is the major concern, especially low uptake of HIV testing. How to driven in part by barriers in formal healthcare sector to service uptake for marginalized and stigmatized population. Thailand National AIDS Strategy to End AIDS by 2030 has been announced in 2014, aiming to achieve third 90 strategy. In order to end AIDS by 2030, as anticipated, one of the key strategies is to engage community-based organizations to respond to HIV as a part of the national health system. Under this national strategy, key population-led health service KPLSS model implement the reach, recruit, test, treat, prevent, retain strategy by utilizing an innovative in prevention, continuum care support, and treatment approach was recognized effective model to help country achieving the target. KPLS FHS offering a variety of quality services tailored to MSM and transgender women's needs. The model was introduced to 9 high-burden provinces on HIV prevalence. When we talk about the KPLSS model, one of the innovations of this model in Thailand has been the use of volunteer. We call peer mobilizers. Peer mobilizer is who recruit new clients from within their social and sexual networks, especially reach to more hidden key population. It's difficult to reach to them. We use the peer. Most of peer can be do like this effectively. If we compare with the more traditional outreach model, peer mobilizers model is very useful. And also, this peer mobilizer represent a cost effectiveness option of expanding program reach to more to provide information on cluster of recruitment. This is very effective. Reaching MSM and trans women who engage with risk behavior is nothing if we could not bring them to access on HIV testing. KPLSS model provided option to testing place and method to tailor with their convenience. We offer testing conducted by trained lay provider through community health center, mobile clinic, sauna, either finger prick and vein blood corrections. In figure year 2017, number testing has increased dramatically from 2016 tests to 8,067 and have a positive about 964. In figure year 16, tests 15,265 and positive is 1,250. And in figure year of 17, which is 76 increase. Through some piloted innovation under the USAID linkages project, community-based training model that have preliminarily show high yield, including sauna-based testing, 13% yield overall in figure year 17. Online recruitment and referral form gay cruising app, 17 yield, and referral of HIV testing client, sexual and social partner, 12.5% yield over the life of the project of the date. What we found, HIV positive client, key population care and support team accompany to achieve ARV treatment as soon as at the hospital or facilitate. CBO were able to link positive client to receive ARV in formal sector at a very high rate, 80% in figure 15 and figure 17. Linkages has started same-day ART approach in Bangkok, which has been expanded to other provinces in figure year 18. Since January 2016, total of 2,100 clients has access PrEP to the Princess PrEP project. The key population rate, the same-day dispensing approach has contributed 46.2%. The key population rate and same-day the key population member access PrEP through the Princess PrEP project already account for more than half all reported Thai PrEP use. And Thai Red Cross, AIDS, Resource Center and local government organization, community-based organization consortium has set up the National Technical Assistance Platform to provide training, quality assessment, quality improvement, and assessment for certification for these lay provider or key population that we concern how to develop their quality. The term of sustainability policy dialogue with national government agencies such as the Ministry of Health, Public Health, National Health Security Office to provide domestic health funding for KPLSS model is commencing. In summary, KPLSS model is a promising model that have proven the effectiveness of task sharing and task shifting between government and community-based organization to end AIDS. Thank you.
Thank you very much, Mr. Pongthorn. And I think that gave us a very clear picture of when we investing in having key population as lay providers to key populations, communities, that at least in Thailand, double up HIV testing rate. More than half of Thai PrEP users are now receiving PrEP through this KP-led PrEP program. And as Mr. Pongthorn just mentioned, the next step is how to sustain this. And we are glad that a few of people from the government of Thailand are now here in this room to share this experience with us. And then I now would like to turn on to our next speaker, Paula Simonson from Norway. And Paula was born into a family of traditional healers and was trained in spiritual medicine and herbs since childhood. She has been living with HIV for 15 years and have been working with HIV field from a holistic point of view, based on traditional and spiritual healing. She is also the frontrunner and the founder of the networking group of Sami Plus, a network for Sami living with HIV/AIDS. Paula, please.
I'm honored to be here, and I will thank the Great Spirit that allows us all to come together here. And I have no presentations with slides because traditional medicine are mostly oral, and it's about awareness and to be present. According to the law in my country, in Norway, we are not allowed to treat people with diagnosis from traditional medicine. And that is also one of my issues. I want it to be legal and that everyone can have access for traditional treatment too. For all people, it's important to be heard, the way they are raised and the way they are living. And in many indigenous communities, we have strong traditional medicine, and we have strong tradition about involving the whole community. And when I work with myself and the HIV and the people around me that have HIV, I see that the community involvement are very important. And also that the healthcare listen to us and acknowledge that we have our own traditions too. We may not have the cure, but we have strong medicines that can help in the daily life, that can strengthen the spirit. And I see that the lack of the spirit leads people into drug use and to sickness. But if you bring in the old traditions about spirit, people may get stronger. And we can get rid of many of the other uses. And according to something that was said here before, the transgender people are in many communities, traditionally they are thought to be very spiritual. Many of them was the spiritual leaders, they were the spiritual healers. But today, in my community, which is the Sami people in the north of Norway, Sweden, Finland, and in Russia, the transgender people does not exist in public. They are totally hidden. So, to bringing in the traditional medicine will raise the quality of life for most of the people from small communities. And what is common in most of the indigenous community I've been spoken to is the holistic view, where you don't look only on the physical body, you also take the emotional and the mental and the spiritual body in, and a fifth body, which I call the social body, the community. If one individual is sick, the whole community becomes sick, and you have to treat the whole being of a human. It's not, you cannot only treat the physical and forget about the spirit. You have to bring all these aspects. And when I meet the health services, I can see that they don't meet my questions in the spiritual realm. If I have some needs to treat my spirit or my emotional things or my mental things, they don't even listen. They say it's nonsense. But to me and to many of the other people in indigenous communities and many other traditions, the spiritual becomes very important, especially when you are sick. So, to bring that in, the awareness of that we are more than just a physical body. We are all spirits, we are all connected in spirit, and we need to treat that too, to get rid of any imbalance in this world. That was what I could say. Thank you.
Thank you, Paula. Thank you so much. I think many of us are aware of how biomedicalized our work in HIV services has become. And Paula reminds us about the fact that we are whole people. We have psychosocial and spiritual dimensions that are often not well addressed in the formal healthcare setting. And so the role of the community, the role of key population providers are very important beyond HIV testing or ART or PrEP, but in addressing all of the other issues that we face. With that, I would like to now turn to a Ministry of Health leader and a policy maker from Vietnam. I'd like to introduce Dr. Phan Thi Thu Hung. She is a Deputy Director for the Vietnam HIV/AIDS program. She has more than 23 years of experience across HIV counseling and testing, ART, PrEP, and community-delivered services. She's also been a great champion related to innovation in Vietnam and clearly sees the role of community-based services as part of Vietnam achieving epidemic control. Thank you. Welcome.
Thank you. Good afternoon. Today I would like to thank the organizer to have me a great chance to share with you a story from Vietnam that how key population lead health services. So up until 2014, the Vietnam Ministry of Health and our partner focused on rolling out HIV testing and care and treatment services through the public sector. However, even though the quality of HIV testing was high, the uptake among key population was relatively low, around 50 to 60% testing for HIV in the last 12 months. So at this time, we start to realize that the HIV epidemic was changing, that HIV was more and more concentrated in urban area and increasing among young MSM. And we were also more aware that transgender women were a separate population that were at high risk for HIV. And when Vietnam adopted the 90-90-90 target from 2014, this opened the door for more innovation and for more key population list service delivery. And we found that CBO had the potential to better reach key population reluctant to come to facility for HIV testing and other services. And the first step was allowing key population CBO to offer HIV late testing and cell testing through Untitled in 6 provinces only. And PATH and WHO partner with very closely with Ministry of Health to implement this pilot and train CBO staff to use single rapid diagnosis test to screen peer for HIV and on how to offer HIV cell testing. And at that time, I observed these CBOs and found their services to be excellent offer with a greater care and communication skill than many trained lab staff that I have seen. They were also very skilled at enable client access to confirmation HIV testing and ART enrollment. And their cascade are much stronger than some that we have seen from the public HIV testing services. So we also see that HIV lay testing and cell testing offered by CBO is much better at reaching with new HIV tester. An evaluation conducted by Ministry of Health and PASS found that nearly 70% of key population coming from HIV lay testing and cell testing have never tested before. So nationwide, more than 100,000 key population have received testing through these services. So around 22% of all tests and have the HIV reactively rate among CBO is around 7.5% compared to facility-based testing is only around less than 2%. So this CBO also now including rapid syphilis and HCV test with HIV testing. And to maximize convenience for the client and focus on the key disease experiences by key population in Vietnam. And they also play a key role in PrEP, screening and follow-up. From 2016, the newfound confidence of key population of CBO also lead to several registering as social interpreters, so they could develop and businesses and make money to contribute to their long-term sustainability. A key role for Ministry of Health is to set standard and to enable legal pathway for HIV services. And since we see key population and CBO as key partner in HIV services delivery, and we've developed services that enable their engagement, and private clinic are also welcome and to allow to offer HIV services according to national standard. And we are also revising legal language to enable key population, CBO, and social enterprise to distribute and sell HIV testing services and HIV cell testing kits, so their role can be sustained as donor funding decline. This including decree that mandate how HIV testing can be offered, including language related to KP CBO services delivery and the role of the social enterprise and private sector in the update of HIV laws. In conclusion, for Vietnam, the key population lead health services were and are essential for epidemic control, and key CBO have proven their professionalism and dedication and close connection to the communities. They are innovative and creative partners that help the Ministry of Health to better respond to new epidemic challenges. Moving forward, the Ministry of Health will continue to find ways to enable the role of the key population CBO in service delivery and in advising and guiding HIV policy. So that is my story to share with you. Thank you so much for listening. Thank you.
Wonderful indeed. Thank you very much. I think that this last talk is really warming up my heart to hear these messages from someone who is at the policy level. In a country where the key populations is really the key of the HIV epidemics, and I think that it is it is quite clear from this last talk that at the policy level, you really need the evidence to convince the policy. So once you can demonstrate equally good or even better cascade, as well as you see that these are innovations, these are creative, and the country is willing to embrace that into part of the health infrastructure of the countries. That is really a very good start of how we now then can think of how to sustain things. What would be the innovative models in terms of financing mechanisms, etc., including how the country will be willing to modify the legal language, because that's the key things that keep people away from accepting that this is a good way or a better way to do, because you're afraid of the need to deal with all those legal barriers. Yeah, so I think we are now ready to open the floor up for the questions.
Yes, so we would love to have questions in terms of those that are already offering services in the community and have advice or have questions to the panelists, or from policymakers that are considering supporting key population-led services that might have questions, or healthcare workers. So please come up and talk with our fantastic panelists. I know most of you aren't very shy. Yes, okay.
Hi, this is Pete Sika from the Thai Red Cross AIDS Research Center. First of all, thanks for all the amazing presentations that you have presented. I'm particularly interested in the Vietnam model. I'm wondering first of all, how did you get the government to be involved? And for the services now that you're transitioning into the sustainable phase, how are your services being funded? Thank you.
Okay, thank you for your question. I think that the story is very long from 2 years ago when we just following the recommendation from WHO for late testing and self-testing. At that time, you know that very difficulty for us when almost in the past the testing following the health system. At that time, we try to import some kind of the oral test, and finger test is very simple way to let the CBO can conduct it. And we submit to Minister of Health the plan for pilot in from the beginning only one province in Ho Chi Minh City, and at that time we send the technical support from CBO and let them try in their group, and they can link with their partner to invite. And you know that after just 1 year, the result is amazing. And we very surprised that a lot of the people have the first time for testing through the CBO, and they also send the first test to confirmation laboratory. The confirmation laboratory is approval from Ministry of Health. So after the confirmation laboratory, they link with the ART treatment. Based on our 2-year pilot, we find a lot of the difficulty and a lot of the technical issue we need to solve. And after that, we developing the guidance from national. And we also just issue the national guideline from last May this year. And we can open for all the provincial levels. They can conduct it, and we can following the CBO can join with us. And how to sustainable this one? I think that the most difficulty for us now is how to have the license of the test kit in Vietnam, because you know that some kinds of test kit already we can have apply from the different, like American is very high cost. So we would like to import some cheaper tests from Thailand or from India. But the most difficulty is that they are not following our regulation of on the document for license. But I think that we preparing for that, and we have the degree on the province, on the CBO, they can apply for the service in Vietnam, and they can following that degree. That degree is not applied for only CBO. That is open for health sector. It's the same as the CBO. We use only criteria as the same criteria. So whatever who can meet with the criteria, they can use the services, and they can earn money from that. Okay.
Great. Thank you so much. Let's go to. Oh no, Mike. Yep. Please go ahead.
Thank you. I'm Nandita Sugandhi from New York. I'm a pediatrician, and I think we're starting to hear and learn more about sort of how gender identity forms in childhood. And I'm wondering, and we have sort of guidance that's coming out around sort of biomedical interventions and making sure that families are sensitized. But given some of the risks that that transgender women and men will face as they grow up, is there anything more we can do from a preventative or social protection standpoint? And this question is for Dr. Hallard and for Alicia as well. Is there anything more we can do to sort of prevent some of this from an earlier age?
Okay, so not my area of expertise in terms of health, but in terms of training, I think we're really poorly trained in working with any vulnerable and marginalised groups. We're often given information which is either blatantly incorrect and biased by the nature of the system that we're taught in, or it's nuanced in a way where it's not given an emphasis, so that certain things in medicine are much more what I call alpha, male, jockstrappy, this is the thing to take seriously, and this is all this touchy-feely stuff that we don't put an emphasis on and those things. I think we really need to go back and look at a number of some things, some courses are good, but many courses really diminish the importance of true participation of affected populations, families, patients having a real say, and the systems also impact on that, so that even if you want to act on it, it makes it difficult. So I think we need to do a lot of work, both in the health systems level and in the universities, to be working on that. That would be my general comment. I do think we can improve, but I also think civil society has a massive amount to do with this, and the example I always give is HIV, where I came out of medical training and had a year, and HIV came upon us in Australia, and the way I had to change how I thought about doing medicine from the get-go made an enormous difference to me, because patients would come in with knowledge, would demand a different way of service. This was in particular gay and bisexual men, and it really taught you to do medicine differently. And I think if we could help empower our civil society and community-based organisations, others, to be as equally demanding of their rights to us, we would improve healthcare for many, many people, and for many, many things. So I would always be encouraging of health systems to fund civil societies to demand better healthcare, because I think in turn it helps us be better healthcare practitioners.
Yeah, I think we are in agreement. I don't think, as a transgender woman, that it's up just to medication, for example. I think the title of the session is the key response, key population-led health services led. We have to be led by the expertise of, for example, transgender persons. Since childhood, we experiment the gender difference between each other. In Ministry of Health, for example, we fund a lot of action
led and done by the civil society. For example, the Live a Better Knowing strategy. We fund pride parades. For example, the São Paulo Pride is the biggest one in worldwide. And it's not just to dance and to show things. We test, we talk about combination prevention, we talk about human rights. I think the key response is the human rights. We have to respond this way. For example, the paradoxical scenario in Brazil, the same country that allows transgender people to apply to be candidate according to their gender, that can change the name and sex in the records so easily, is the same country that most murders transgender population. I think we have to improve the legal scenario, not just in Brazil, but worldwide. In some places it's illegal to be trans, for example. In Brazil it's not illegal to be trans, but it's not totally safe. Concerning the transition process, medicines are important. Surgeries might be important in some cases, but supporting, psychological supporting, and the expertise of transgender persons, it must be taken in account. We have to take in account the expertise. Transgender persons must lead your own actions in healthcare, in schooling, in housing, for example. I think it's a kind of that.
Thank you. Dr. Prapan.
Yeah, Prapan Panupak from Thailand. I would like to congratulate Vietnam in terms of progressing so rapidly in training the lay providers to help the government in doing the HIV services here. I would like to learn from Vietnam. What is your strategies in terms of convincing the government to make the government feel that the healthcare system of Vietnam is not failing? That's why you need to help the lay people to help the government. That's number one. How to convince the government that the health system in the country is not failing now, and how to convince the professional societies like medical technologists that their jobs are not being stolen away by the lay people. So how you do this kind of two strategies? We would like to learn from Vietnam.
Okay, thank you for your question. In fact, the health system in Vietnam is not failing. I think that because you know that the HIV/AIDS patients, they have stigma by themselves. It's not so they still don't want to go to health system, especially that in Vietnam, especially in some mountainous province, very difficult to get the health system, because you know that the road, even they take like a half a day to go from the commune level to the health district to take a test. So we open the self-testing and lay testing in mountainous provinces and in some big city with the same way that the people can easy to contact in their group for IDU group and in MSM group. So we just showing that the number of the people in the community, they want to test, and whatever they want, they can link approach with the groups, they can take a test. So in Vietnam, we the health system, we train for all the health staff, and they also join. Even in health sector staff, in communities, they also join the self-testing and lay testing. So in that we, they also give more technical support for CBO. It's not CBO working by themselves. In fact, they cooperate very closely with the healthcare staff in communities.
So it's an open-mindedness from the government and from the health professionals, and ask them to work together.
Yeah,
is that what you say? Thank you very much.
Yeah.
Can I make a comment that Thailand's not the only place that might run into a problem with health professionals being uncomfortable about losing work or their jobs? We ran into exactly the same problem with community-based testing for HIV, and also with my colleagues in hepatology. when we were saying that primary care doctors and nurses could treat hepatitis C, the anxiety around this was palpable. I mean, this was something that's so simple to do. And we had to, in a way, bring them along on a journey, which I think has taken us a number of years. I think we're there now, but it's really taken 5 to 10 years to bring them on a journey that they will still have a role, and their role is vital, but it's a different role to what they were playing previously. And I think it's an ongoing conversation of anxiety with our colleagues that they think we're diminishing their role. I think we have to really think cleverly about how to make sure that they don't feel that, but that we're changing their role. That their role is to support and to mentor these people as opposed to have to do that task necessarily anymore. And that they'll get the complex ones, the hard ones. We play to their intellect, that you'll get the tough stuff and these people are doing the easy. It's manipulative in this, but I think it's a problem globally. I think you highlight a really big issue of moving tasks.
Thank you. So that's like differentiated healthcare providers, right? Yeah. From microphone 1, please.
I thought you were first.
Oh, sorry. Yes.
Right?
Yes. Go ahead.
Oh, I'm sorry. Alain Vollian from the European AIDS Treatment Group.
Hi.
Sorry.
I'm over here.
We'll manage.
So first of all, my name is Alicia Kerr. I work in a pharmacy in the United States as a community health outreach coordinator. I want to thank everyone for really enlightening discussions today. And then sort of stepping away from the prevention aspect of it, I was wondering how we foster safe spaces where people who are criminalized or who are massively stigmatized are able to do this self-advocacy and develop programs that really benefit them. That's it.
Great question. Svetlana?
Yeah, thank you for your question. Yeah, for us it's very extremely important issue to create safety especially for people who use drugs, because they're very severe criminalized in my region, and actually it's really difficult to build such a system which provide security for them, and now we are having a lot of discussion about how we can react on urgent needs of people who use drugs, who is human rights activists, to protect them from their governments, for their police officer, and unfortunately, I can observe that in my region we still not such a system, and our task to build this one. And really, I have no clear answer about this. It's our pain, but we really feel like without any tool, provision, support, we need resources for this. We need more knowledge, and we also need more pressure from the international actors as well.
Alicia, did you want to answer about safe spaces? Would you like to
I think it's almost the same point. Not being legal is not the same to be legal or to be safe. For example, in Brazil, beside the funding of civil society activism, as I said in my presentation, beside because I work at the Ministry of Health, but we are trying to put more transgender people in the decisions, in the committees, making decisions committees. For example, we have a specific working group on combination prevention. It's a mix of university, researchers and expertises, and the civil society together with us. And then we can listen to the academy, we can listen to the researchers, because it's important. Yeah, I am a researcher as well. But we have to listen the key populations, because we feel it in our skin. We live it every day. So it's very important to let the led by the key population. It's very important to mix universities, researchers, donors as well, in the same group, listening each other, and then make the best decision. In Brazil, it's not illegal to be trans, but it's not safe, as you see. I think it's that.
Yes, and then microphone 1 and 2, who came first? I actually don't know. So you go first, yeah.
Hi, I'm Dina Bons. I'm the chair of TGU, Transgender Europe, and I'm also a sex work activist, so I try to combine those areas. As well, I'm involved in HIV here in the Netherlands, in the Foundation for People Living with HIV. And I think the narrative that what I wanted to share is that it's important that people hear not only our stories, but also understand the context where people are coming from. Many people in the trans community, but also in the key population communities, have had quite some trauma in their life. And it's very hard sometimes for them to overcome this trauma. So I think that is also very needed if you want to do a project, that you need to have time and space as well, where it is safe for people to be. And I think from there as well, to answer the question of the lady over there, it's very possible to get the resilience from those people if they are empowered, and they can get back to the source of where they came from, because many of us have academic grades, but do not work because we're jobless, and this is all because you're bullied out of a system. So if you give people back their power, it's really possible for them to contribute, and especially when it comes to the prevention, and as well talking the narratives to academics, doctors, and then you combine that knowledge, and then I think you really can start to do something valuable. Here in Amsterdam, we have a very low-key trans clinic. We organize it ourselves within the sex work community. And it's simple, just the fact that there is an office open on Sunday. Doctors are coming in, they do their work for free. Nurses are there in, they do their work for free. So this is out their own jobs. But they provide information. They can do prescriptions for hormones. And we do as well HIV testing. So you combine it. And then people see that they don't only go to the doctor, but they're really there in their family, and they can talk about everything that is happening to them, from violence to all kinds of things within their families. And as well, counseling on HIV is very good when it's done peer-to-peer. So if you have people who are like long-time survivors talking to people who just received their diagnosis, this is where the action is. And I think it's all quite simple. The only thing is that we really need donors to understand that everybody from those communities are not academics. So there needs to be an awareness that those people speak sometimes different language. Mm-hmm. So it's not the academic language. And they should not be excluded, because the real value and experience is in those people.
Yeah, that's a really wonderful comment. Thank you so much. Yeah, and then we come to the last question.
Yes, Alain Vollian from the European AIDS Treatment Group in Thailand and France as well. What's striking to me here is that this is a great session because it has to do mostly about recognition of communities, their roles in the fight against AIDS. And in a way, I'm sad that it's still happening, that we still have these discussions, because communities are still not recognized apparently fully on the topic. I think, Margaret, you addressed one issue. I don't remember if it was you precisely, but the collection of data is something that was addressed in a meeting that was outside of the conference I was in yesterday. And it didn't seem very clear to people that communities can also collect data that would support research, would support policy from authorities. And I would like to have your overview and other panelists as well on this topic, very key topic of recognition, because it starts with recognition as well for community-based organizations. How do they collect data and how much that is respected according to different authorities?
I think it's a really, thank you for the comment and the question. I think it's a real issue, and I'll put it in a couple of ways. I was on a WHO guidelines panel a few years ago where we were having to make recommendations. They use these PICO things, which, again, I think I mentioned I'm not particularly process-driven, but they're the rules. And you talk about the strength of evidence, and how do we, getting back to a question or a comment that was made earlier, how do we get things funded and get governments to change, is to provide governments with clear guidelines and recommendations about what's effective with strong recommendations, high-quality evidence. The reality is the data to show that the involvement of peers in all sorts of things is effective and cost-effective is not there when you look for it. Despite the years that have passed, we have failed to do quality work to prove the importance of community. We know it intuitively. You don't need to be a rocket science, but sometimes in trying to convince a government how to affect change, why to put money there as opposed to there, it really is helpful. So I think it is a thing that we need to do a lot more work on over the next few years, is working with community in terms of making sure they're collecting data in a way that makes, because I agree that invariably community orgs can be very savvy. It's not like they're incapable of collecting data in a way that's useful, but sometimes it's ignorance, so that they're collecting something you think, oh drats, if we just got you a little bit before. But then if you work closely with your community orgs, then they can collect information in a way that you can't. If you provide some support and training, then you can begin to get the data to show the effectiveness of the impact of community. So this is where you do need community and researchers and clinicians and all those things to work closely together. I've got to say, as a person, it's really tough to get research dollars for that. And I've only, after 15 years, recently been able to land a grant that, Jenny, the person I mentioned, used to whack me over the head saying, why don't you do a peer this? Why don't you do? I said, Jenny, it's not for want of asking for money. So it's very hard as a researcher to get dollars to give to community to do that training and collect it. But I think it's vitally important that we try to.
So thank you very much, and we're nearing the end of our session, so we would like our amazing panelists to provide one message that you would like the audience here to leave with. It can be a next step, a strategy, any kind of take-home message. And Svetlana, would you like to start?
My key message must be about structural violence and criminalization, not only people who use drugs, by all vulnerable communities. So if we stop structural violence, we will stop AIDS.
Thank you. We are not just one thing. I am not just transgender. I am a woman. I can use drugs. I can, for example, adopt the traditional medicine. We are not just one thing. We are a diversity within the only unique person. So I would like to finish by saying that our association in Brazil is trying to make different with a depathologization approach, different from some parts of the world. We are trying to do our own SOCs, standards of care in Brazil, together with WPATH, but with our own approaches in Brazil, specific to our population. So as in Africa, Ubuntu, I am because you are. And I am trans, I am happy, I am happy, really happy because you are here now. And I would like to finish by saying that nothing about us without us. Thank you so much.
If we're going to end HIV, eliminate viral hepatitis, stop TB, whatever these things are, we have to recognise that civil society has a central role in all of that. We will get nowhere without the community, affected communities, being central to the response. And that includes working with health services, with clinicians, with universities, with researchers, with departments of health in helping us improve our responses so that they are appropriate to the needs of the community, and so community are engaged. And that then helps us get the funding to shift the money where it should be.
My last sentence, in terms of sustainability, it is a major concern about how to engage community to involve our success. It's very important when we talk about meaningful participation. In each of the process, we should concern how to encourage them to work together. It's not just the policy maker. We should concern the bottom line of the community to involve in this state. I think it's a very major concern for me.
According to the key population and the communities, ask them what they need, listen to them and act. Let the communities and the key population be involved. And most of the world are spiritual and traditional, and many of the traditional are thousands of years old. They have been delivered from generation to generations for thousands of years. How can we ignore the traditions that people use daily? To me, it is very strange to see that after all these years of AIDS work, it's not involved at all. So bring forth the traditions also, which is so old and so much used all over the world. Thank you.
So, as a policymaker, I know that I learn a lot from the key population. So that's why I'm working very closely with them, and I regularly to discuss with them that how they need and what they want and how difficulty to solve. And we also thinking about that all the legal document need fair. It's not only for health system, but also it's open for every services they want, they have to follow. That is one of the first criteria when I'm working for this session. Okay.
Thank you very much, and thank you all of our panels here. And if we can give another applause to everyone here. And my one sentence here is that I hope that this panel at least help you to open up your mindset, loosen it. Let it being a growing mindset, and I think that's important. Whether you be a key populations, whether you be a healthcare providers or policy makers, to allow yourself to learn from each other, so that we can work more fruitfully to end AIDS. Yeah.
So, we know that what got us here is not going to get us there, and we know clearly that key population-led organizations are delivering excellent services, and that's demonstrated from the panelists here, but not just in the countries represented here, but all over the world. They're service providers, they're researchers, they're advocates, and they are the answer to the HIV epidemic. And so as we think about next steps, what we can do next in the community, I can only echo what Nitya said, is just wherever you are to think about how you can further enable key population-delivered services
services. And this is particularly a call to policymakers, those in ministries of health, who can make decisions around the law, who can make decisions around financing, and who can further enable partnerships with the community. I would lastly like to thank Dr. Nitya, because really this session came about because of her quiet advocacy, quiet and very excellent advocacy. So big thank you to you as well.
Yeah.